谢谢各位医师来参与我们今天的会议。那我们的时间已经差不多了，我们会准时开始。那我们现在的讲者以及座长也都在线上了。那我们欢迎黄吉仁理事长为我们 opening。
会员还有各位线上的我们的学员还有我们的贵宾主持人哈，因为今天我们是有外宾，所以呢我的 opening remarks 我要用英文来讲一下所以请接受一下我的英文。Hello everyone, hope all of you are being well today. My name is Chip-Yin and it's my privilege and great honor on behalf of the Taiwan Society of Emergency Medicine to welcome you here. Thank you for making the time to join today's session, Emergency Medicine Model of Clinical Practice during COVID pandemic era. It is especially a great moment to have Dr. Sunny Wong and Professor Terence Morgan with us. Both of them are outstanding practice physicians in the United States. Over the past year, the outbreak of COVID have dramatically changed the world and our life. As frontline emergency doctors, we are facing a challenge with almost impossible to describe the impact that we can have. And before we begin, I would like to remind you to use the Q&A function in Zoom and submit your questions so we could discuss them later. Now, let today's distinguished speakers tell us about their experience. Now, I will pass the first section to our section chair, Dr. Chen Wei-Kong, to welcome. Let us give a warm applause to welcome Dr. Chen Wei-Kong. Thank you all.
Okay, 谢谢 Chairman Dr. Huang 的 introduction。我先用中文先讲一下哈。那我们今天有邀请到这个的贵宾是Dr. 王，好，那我就用英文来跟大家做个介绍，因为今天有其他的贵宾。Okay, good morning, ladies and gentlemen. We start the first topic. We welcome the invited speaker, Dr. Sunny Wang. I briefly introduced the Dr. Wang. Dr. Wang was graduated from the Medical School of the Duke University in 2007. He received the resident training at the University of Cincinnati. He was the department chair and the medical director at the Mercy Anderson from 2007 to 20. Now, Dr. Wang affiliated with the Mercy Health Anderson Hospital and the University of the Cincinnati Medical Center. Let's welcome Dr. Wang to start the first topic. Please, Dr. Wang, Sunny.
Hi, thank you. So thank you, Dr. Chen, for the very nice introduction. And hello, everybody. My name is Sunny Wang, and it is my pleasure and my honor to be invited to be speaking to you today. And here I'm going to share my screen. Actually, all right. All right, can everybody see my screen okay? Can see my presentation here? Okay, great.
Yes.
So it is my honor today to be invited to talk to you about the use of telemedicine in emergency medicine during the COVID-19 pandemic. Now, since we have 30 minutes, I thought I would focus a little bit more first on how telemedicine was used specifically in our field, in our specialty, and then if there's more specific details of how it actually operates or what it was like to see patients using telemedicine, I'll be happy to address that during our Q&A session as well. So as most of you know, telemedicine already existed before the COVID pandemic. However, the acceptance was low. And this is both true on the patient and provider side. Not only there's technology, but I think also just we're all creature of habits, right? We're used to the face-to-face interaction. So there's always question as to whether this technology is really gonna work or not. And then on top of that, there was, at least in the United States, there are limitations by regulation. So, and for example, a lot of times it was initially, it was really only accepted for rural area to be using telemedicine. And reimbursement rate is also lower for telemedicine. So in February of 2020, CDC issued guidance on social distancing, including the recommendation for healthcare providers to provide telemedicine service. And in order for that to take off, really some regulation needed to change. And I wanted to also mention that before the pandemic, there was already 4 pretty large telemedicine service providers, and these are MWell, Teladoc, MD Live, and Doctor on Demand. So regulatory changes, the big ones that really impacted us was HHS, which is Health and Human Services, announced that it will waive penalty for HIPAA violation against healthcare providers for providing telemedicine services through non-public facing technology. So what that means was, before this waiver, if you were going to see patient using FaceTime, Facebook Messenger, Skype, etc., that is actually considered a HIPAA violation, because these technologies considered non-secure. There's additional security risk there that somebody could hack and also see the patient information, but that was waived. And this was actually kind of important because these are kind of the technology that a lot of people are familiar with already. So rather than make hospitals develop a new platform, or provider or patients try and learn a new technology, a new platform, you're really allowing them to use something they're already familiar with, and therefore the acceptance and of using telemedicine is going to be a lot higher. Medicare also expanded its payment program set to include pretty much all telemedicine visit, which was new. This did not exist prior to the pandemic. And they now are willing to pay it at the same rate as any in-person visit. And that kicked into effect on March 6th of 2020. And later, as the pandemic got worse and worse, more and more state governors waived the state medical licensure requirement. So this probably is more unique to the United States. This is not as important for Taiwan, probably, because you guys have one license and you can practice in the whole country. But that became important in the United States because this really allowed clinicians to start provide telemedicine service across the state line. And what we really did not expect it was such dramatic volume drop in patient volume in ED and urgent care. So when the United States declared a national public health emergency in March of 2020, urgent care and emergency department were really preparing for an onslaught of patients. We honestly thought we're going to get annihilated by just like huge amount of patients start swarming into the ED. But instead, really, other than certain pocket area where you see really bad outbreaks, so like New York City, Seattle, and later on Texas and Florida, pretty much across the board, everybody saw very dramatic volume drop. And just to kind of give you an idea how big of a change we're talking about. So this is based on a survey from the ED Benchmark Alliance, which has about 1,500 ED members. It put out a survey in May of last year. 400 members responded, and so this is the data averaging from the 400 members. We saw, in general, volume increase in January and February compared to 2019. March is the first month we saw volume drop, and really, if you talk to these members, they say it's really the last 2 weeks of March. In the beginning of March, we're still on track to see more patients than 2019, but the second half of March just really volume dropped. So April was the first month that we saw a sustained volume drop across the whole month, and that was 48% volume drop. And certain specialty ED, so like pediatric ED, even saw volume drop as much as 71%. So this is huge to lose like 71% of your patient. So that has pretty severe financial impact as well. Pretty much across the board, everybody was cutting shifts or at least cutting hours. So now you have a lot of ED clinicians that could be physician, PA, or NPs that all suddenly sitting at home and not working. Many ED groups have to resort to cutting wages. So unless they're 100% RVU pay model, as long as there's some sort of guaranteed base wage, all those had to be cut, as well as administrative stipend benefits in order for these ED groups to even survive financially. And we also heard a lot of new residency trained EM graduates who were graduating in June of 2020 saying their job contract has been rescinded, like their job just vanished overnight. At the same time, though, telemedicine was taking off. So this graph is provided by CDC. The light blue bars you're seeing is the total telemedicine encounter in 2019 versus the dark blue bar is 2020. So you can see even before the pandemic, there was more usage of telemedicine in 2020 compared to 2019. So there's overall, what this is telling us is that there's increase in acceptance to telemedicine to begin with. Now, I should also mention, this is data from the 4 largest telemedicine provider that I mentioned earlier. So MWell, Teladoc, Doctor on Demand, and MD Live. So this is their aggregated data from these 4 companies. And then you saw on week 10, that's when the CMS telehealth waiver kicked into effect on March 6th. And that's when telehealth visit really started to skyrocket versus ED visit really started to downtrend. Now, I should mention the dotted line is the percent change of ED visit 2019 compared to 2020. So that's that line really started to drop off while the telemedicine visit really started to pick up. So to put that into numbers, if you just look at week 13 alone, there was 154% increase in demand for telemedicine compared to the exact same week in 2019. And on top of that, proportion of COVID-19 related encounter increased from 5.5% to 16.2% during that last 3 weeks of March. So really, COVID outbreak is really, the numbers really starting to skyrocket that second half of March. And it's not just emergency medicine. So this graph is provided by McKinsey, which is a consulting service firm. They look at data across all specialty. Now, this one does not include emergency medicine, but include pretty much all other specialty like dermatology, neurology, ophthalmology, pretty much everybody else. And you can see telemedicine really peaked in April of 2020. And later on, as people start to get more comfortable being back in person visit again, there was a little bit taper in the demand, but as you can see that it's still sustained and quite significant volume still compared to prior years. So for emergency medicine specifically, we use telemedicine in multiple different ways. Probably the most common one that people can, or most people are most familiar is using it as a virtual urgent care. So this is where we use telemedicine to see urgent care type of patient, like lower acuity patient. And this can be either through a hospital platform or independent platform like Teladoc or Doctor on Demand. For the purpose of this talk, I will use Teladoc as an example more because I'm familiar with it, but it's definitely not intended as an endorsement. And I'll also just let you guys know I no longer work as a physician for Teladoc, so I have no financial interest here. And then we also use telemedicine as a way of resource management tool. As I mentioned earlier, we start cutting shifts across the board. But the problem is, emergency department, we never know when you're suddenly going to have 10 patients check in at any point in time. So suddenly your ED may become very understaffed dealing with these small surges throughout the day. So we come up with a way of using telemedicine to kind of help deal with these surges. And then also we use telemedicine within our own department as a way to conserve our PPE. And we'll also get into a little bit more of that as we discuss this. So in terms of using it as a virtual urgent care center, majority of the hospital didn't have the time to really develop their own platform. And so pre-existing platform like Teladoc, Doctor on Demand, they really had an advantage here. They simply just basically took over market share. They are independent of any hospital system, meaning they do not share medical records with a hospital. So these patients, when they come on Teladoc and I see them, I cannot see any of their records from any other hospital. However, if they've been on Teladoc before, since Teladoc owns their own medical record, I can see their previous Teladoc visit. So sometimes that's helpful, especially in rash complaint. If they say they've been on Teladoc 2 days before for a rash, and now they come back 2 days later because their rash got worse, usually I have pictures from a prior visit, or if nothing else, at least a medical record from a prior visit as a comparison. So acceptance was also relatively low prior to pandemic, even on these independent platforms. And just to give people some idea of what numbers we're talking about, in Q2, so that's April through June of 2019, they saw 908,000 visits versus the same time period in 2020, they saw 2.8 million visits. So that's 203% increase in patient volume year over year. Obviously, this is because during the pandemic, patients were choosing to stay home. They didn't feel comfortable going to emergency department because they're afraid to contract COVID. And then so patients with low acuity are definitely utilizing these services a lot more. Now, that being said, there's definitely plenty of data published saying that even complaints like chest pain, shortness of breath, belly pain, these kind of potentially higher acuity complaints, they also dropped off. So really the concern was patients were delaying their care because they're afraid to come to the emergency department. And because there was such an increase in demand, all these platforms were seeing significant wait time. So now these patients in the past, before the pandemic, it may take like maybe 5 minutes for them before they see a patient, before they see the doctor on Teladoc. When we signed on to help in March and April, these patients sometimes waited 2 or 3 days and have not yet seen a doctor on Teladoc. So that's when Teladoc came to my company specifically, which is US Acute Care Solutions. We came up with a partnership solution that was a win-win situation because we were cutting shifts and cutting clinical hours. So we have a lot of physicians sitting at home versus Teladoc saying we need at least 1,000 physicians to help decompress, the volume or to handle the volume that we have. So we kind of formed an agreement. We kind of got emergency credentialed. And then overnight, pretty much my entire company got on Teladoc and started helping them see patients. So the way this works is Teladoc already had pre-existing contract with multiple insurance company and major employers. So as long as the patients have eligible plan, they can sign up and see a physician on Teladoc. And when they may not have any more additional copay, it can be all covered by their plan already. And then versus patient without insurance or doesn't have a plan with Teladoc, they can still pay for a visit as a flat rate service. So once a patient initiate a request, so these are obviously patients that initiate to be seen, just like patient will come to the ED or urgent care request to be seen. They usually have to enter chief complaint, update their medication list, medical history, upload any relevant pictures. So like a rash, a lot of times they will upload several pictures. So I already get to see these pictures before I even see the patient. And then just like you see a patient in the ED, you'll see them, but just using, a video, some sort of video chat screen. You complete a chart and then you prescribe the medicine. Prescription are all sent electronically, so the patient doesn't have to go somewhere to pick up a prescription. It's already sent to a pharmacy that was designated by the patient, so patients just go pick up the medicine directly. And also, we do not prescribe any controlled substance, and that's because pretty much almost all states have the requirement that you have to have a hard signature on paper for any controlled substance. And I should also mention that the electronic prescription that already exists even on hospital EMR before the pandemic. So even before the pandemic, when the patient come to my emergency department, I could prescribe electronically already. So that's not something new to the pandemic. Obviously, there's limitation, and I think this is why a lot of times before the pandemic, people have reservation about using telemedicine. First of all, you have very limited subjective data. So like vital signs, even if the patients have thermometer, blood pressure machine, or pulse oximeter at home, you're really counting on them using it correctly in order to report accurate data to you. Most platforms don't support lab or imaging, and that includes Teladoc as well. So if a patient come in and has what looks like a pretty bad ankle sprain, and I'm concerned there's a possibility of avulsion fracture, I have no way of ordering an x-ray. So I'm still going to have to refer this patient to go to a local urgent care or emergency department to be seen. Obviously, limited exam, including ear, nose, and throat. So these could have been a minor complaint in the emergency department, but otherwise through telemedicine, we really can examine their ears. Now, that being said, more and more companies are now developing technologies to try to break down this barrier. So for example, I know a lot of platforms are now doing video recording of how patients can do their own self-exam. And there's video teaching patients how to do exams. And then you report the finding to the physician on telemedicine, through telemedicine platform. So I know people are trying to overcome this. Now, obviously, and then also the last one is technology limitations. So you really dependent on having adequate internet speed in order to have quality audio and video conferencing. And also there's always operator errors, people clicking on the wrong button and then you accidentally disconnect. Now, from the provider side, there's also a lot of advantage though to telemedicine. First of all, as an ED physician, it was a breath of fresh air when I realized I'm only seeing one patient at a time. We're so used to having a lot of distraction and seeing multiple patients. But really on telemedicine, especially with Teladoc, it forces you to close out a chart before you're even allowed to pick up another patient. So you really can only see one patient at a time. And also patient can enter a lot of information before any consultation. So it really, the encounters are really fast. Like on average, once you get used to the platform, you can easily see a patient in less than 5 minutes on Teladoc. Also, what I do appreciate on telemedicine was we start seeing patients in their home. So that really provided insight into their living environment. What exactly are they eating? How are they securing their medicine? And are they taking their medicine accurately? So that's what's really helpful as well. And then another thing is that physician can work very short shift because now you no longer have the commute issue. You can even work a 2-hour shift, 4-hour shift. And even as independent contractor with Teladoc, you can see patient, you can pick up one patient and hop off and go do something else and then come back and see 2 more patients and go do something else. So there's a lot of flexibility that telemedicine offered. Now, specific to the COVID pandemic, telemedicine also had the additional benefit that you don't have to worry about PPE. And it was a great tool to triage these COVID cases, especially early on in the pandemic. A lot of time, these patients, they really just need a reassurance or education. A lot of times they were actually sent in by their employer to get a work note. So these are really simple cases that really save the resources at local ED. Some of you may know in the United States, we really struggle with our testing capability as well as PPE early on in the pandemic. By that, just to give you an idea, like state of Ohio, I remember back in March, we have the ability to test 300 patients per week for the entire state of Ohio in March. So it was highly restricted as to who you can even test. So there was really no point for some of these patients that we're pretty confident they have COVID. But even through telemedicine, I can tell them, look, you don't meet the requirement to be tested right now. So I think you have COVID, but you right now look okay. So my best advice is you just stay home until you don't, and then if you feel sicker, you're obviously welcome to go to the emergency department and get seen there. And what that does too, it does conserve the PPE at local emergency room, pretty much across the nation. And in the United States at that time, we faced severe N95 shortage. There are physicians in New York and Seattle reporting that they get one N95 mask per week. And that's it. Like you have to make it last 7 days before you get another one. So that was helpful that we were able to see as many patients as possible through telemedicine. So in terms of resource management, what do I mean by that? In general, at least in the United States, even when you have rural ED that maybe see like 12, 24 patients a day, you still have to staff a physician even when they're not seeing patients. So usually there's some guaranteed base wages for these physicians. So they're being paid even though they're not seeing patients. At the same time, we're cutting shifts at the more urban or city ED. And so, but the problem now is you never know if you're in the city when, 5 or 10 patients are going to check in less than 30 minutes. So now suddenly you're understaffed. So what we came up with was essentially you can really use the physician that's sitting in an ED that is completely empty and not seeing patients to really help the physician that is in a busy ED and getting overwhelmed. Now, this obviously will only work if you're in the same health system and have the same EMR. So because otherwise, just trying to share medical record, it's just like in Taiwan, trying to share record from Longzhong to say Guotai, like these hospitals, you can't connect in real time together. So this obviously only works if you're in the same health system. So for example, like Guotai Hsinchu Fenyuan can help the physician at the main campus in Taipei City if the Taipei City's campus is getting overwhelmed. And we have used some of this even before the pandemic, but I really felt like pandemic forced us to really do this and do this well. So specifically, the way this will work is that when the ED is overwhelmed, they look at their partner hospital and see whoever is not busy. The triage nurse will call over and say, hey, we're getting busy. Can the doc there help us and at least triage some patients in the waiting room? Then the doc will order tests, so obviously talk to the patient. And you can use your triage nurse to help do some exams. So a lot of times I will ask the triage nurse, listen to the lungs for me. Do you hear wheezing? Do you hear crackle? Now you'll have to trust the nurse exam. So there's obviously that limitation, but it's at least better than nothing and better than a lay person, And then usually I will order tests, write my triage note. And then the clinician at that busy ED can eventually take over the patient care. And a lot of times by the time they get to see the patient, the lab results are back, x-ray results are back. And all they really have, as long as they don't want to order more tests, they can just dispose the patient. So it's become a very effective method to decompress a very busy emergency department. So we're most likely going to continue use some of this as well, even after the pandemic. And then what I meant by conserving PPE was during the pandemic, we really had to modify our process so we don't use the PPE unnecessarily. N95 was one of the in critical shortage pretty much across the board, across the country. But even say isolation gowns, even our PAPR hoods, we were constantly trying to figure out how to re-sterilize these things because we really couldn't afford to waste them. So what we decided was, at least in the United States, our typical model is patient come in, we see them, we order tests, and usually we go back into the patient's room to update them on their test results and discuss with them what is the next step, whether they're going home, are they being admitted to the hospital, etc. What we found was that you really can use telemedicine on that second part. You don't really have to physically re-enter the patient's room to update them on their test results or discuss a disposition. What we end up doing is we make sure every patient room had a landline or some sort of telephone or cell phone that's available, and we then call back into the patient's room to update them on their test results and then discuss the next step. So that really saved a lot of time on donning and doffing the PPE as well. As we all know, taking off PPE is actually really important step because that's when contamination can occur. So we also usually use a spotter as well. So you're saving the time, not only the physician time from having to put on and take off another set of PPE, you're also saving us the time of a spotter. So that become a great way to conserve time as well. And on top of that, it is another form of social distancing because if this patient does have COVID, you're kind of reducing the chance of the physician having, the chance of contracting COVID from the patient. The more face time you have, the more likely that's going to happen. So these are kind of the ways we utilize telemedicine kind of early on in the pandemic. So kind of to conclude everything, I felt like telemedicine was definitely available, just not widely accepted before the COVID pandemic. Emergency physicians were in great demand in the beginning of the pandemic to provide telemedicine service because we are good at dealing with undifferentiated complaint. So we are really good at screening patients through telemedicine. It is definitely an effective tool to manage certain complaints, and I can see that it will replace in-person visit, and this is likely to stay even after the pandemic. And as well as creative use of telemedicine during this pandemic really taught us, how we can conserve our human resources as well as our PPE. So I think our time is about up. So I'm gonna say thank you for listening, and I look forward to our discussion during the Q&A session.
Okay, very thank you, Dr. Wang, give us so important information about the change of the ED and during the pandemic and the role of emergency physician in the telemedicine during the outbreak. Yeah, it's very important for us to think about the role of the emergency physician in the future. Okay, let's go to the next topic. The moderator is Professor Lin. Professor Lin, please.
Okay, thank you, Dr. Chen. It is my honor to be the moderator of this session to introduce Professor Terry Mulligan. It is a difficult task to introduce Professor Mulligan because he has many areas of interest and specialty. In addition to his Doctor of Osteopathic Medicine degree, he also had a degree of Master in Public Health, and he also had a subspecialty and a fellowship training in many areas such as health policy, emergency medicine administration, health economics, policy, and law. And he also had a subspecialty in international emergency medicine. He also had a subspecialty in sports and exercise medicine. So he has wide area of interest and achievement. And he is an adjunct professor in emergency medicine at the University of Maryland School of Medicine. He contributed heavily in the emergency medicine development in Netherlands and also in other 50 countries in the world. And he now is the board member of AAEM, and he is also the vice president of IFEM, 是世界急诊医学会的副总裁了哈。And he got many awards. In the year of 2010, he was honored with the special award, the Order of the IFEM. 这个是 IFEM 的勋爵啦哈。He got many awards, so I cannot read it in detail. Finally, I would like to point out in the year of 2018, he got the President Awards from the ASAP and the AAEM. I think that Dr. Mulligan is going to give us an important speech on public health emergency, the role of the emergency medicine in the pandemic area. Let's welcome Professor Mulligan. Professor Mulligan,
hello.
Hi, you can begin your speech. Welcome.
Hello.
Hello.
Thank you so much for the end. Let me switch over my slides here. So thank you very much for the introduction. Thank you for the invitation. It's really my honor and pleasure speaking with you today, or I should say tonight, where it's find you in time. And my name is Terry Mulligan. I'm an emergency physician. I was trained in the USA. And I'm going to talk about public health emergencies, the role of emergency medicine in the pandemic. I mentioned I was trained as an emergency medicine specialist in the USA, but I was also trained for residency in how to build the system of emergency medicine. You know, medical school and your residency teaches you how to take care of patients, but it doesn't really teach you how to build the system. And so I became very interested in how do you actually build an emergency medicine system in a place that maybe has no emergency, or a place that has a good emergency, but maybe needs a little assistance. And as you may know, emergency medicine is not fully developed in most places around the world yet. And so I became kind of obsessed with this and wanted to learn as much as I could about how to build emergency systems in addition to how to take care of emergency patients. So one of those areas was training in public health. So I went to public health school before medical school, and then after medical school, I finished the master's degree at George Washington University, and I did a number of different training programs on how do you actually build emergency systems. So today I want to talk about what is the role of emergency medicine, particularly in public health, and what is the role of emergency medicine for the pandemic. I don't have any financial disclosures to make. This is my email and my Twitter. In case any of you are interested in contacting me, please feel free. I would be happy to share these slides with you as well, or answer any other questions. So this is probably the most challenging year that all of us have faced, at least in my whole career, and probably many of us in our entire career all around the world. I've spent, like most of you, the last 15 months or so up to my ears in the ER, taking care of sick COVID, the stress on the system that the pandemic has caused. And although I don't wear this outfit when I'm in at work, I sometimes feel like we're back in the old days of the pandemic of long ago in history. In my training, I've been involved in writing chapters for emergency public health with my colleagues, Dr. Kapoor and Dr. Smith, and also chapters on the role of EMS and ambulance systems in pandemics and in disasters. And so I think a lot of us in emergency medicine, while we were very challenged with the pandemic, this was something that we were kind of familiar with, and we've kind of been trained in it. Right now, I'm on the board of directors of the American Academy for Emergency Medicine, and I'm also the vice president of the International Federation for Emergency Medicine, which is a society of all the emergency societies in the world. And just to show you some who is represented by the International Federation for Emergency Medicine, you can see that we're represented by 6 out of 7 continents, and our constituency is changing, and we can see we have many, many more members, not just member countries, but member individuals coming from countries in the Australasian Pacific Rim area. Also, demographics of our constituency, like the demographics and gender distribution of medicine itself, is changing to become more represented by females in the world, but also in the IFEM. I had the pleasure of being invited to speak at the 2018 conference I just had a wonderful time meeting old friends, meeting new friends, meeting Dr. Tsai, who he and I went to the same medical school and didn't even know that. And so he's working there. And I was very happy to see the city and to have some traveling and tourism. And so I very much look forward to the date when we can all share the same space with each other, have a conference the old-fashioned way, and go to our favorite restaurants and some of my the best food I've ever had. So I look forward to that hopefully soon. So all of us have been consumed by the pandemic and the way the pandemic has impacted our jobs, our profession, but also every other aspect of our lives. The United States itself had one of the most disorganized, politically complicated, and inadequate response to the pandemic out of almost every country. And we have one of the highest infection rates, one of the highest death rates, and one of the highest prevalence and incidence for COVID out of almost any country in the world. What we've seen is how COVID has spread to almost every country. This is data as of 2 days ago, showing 33 million confirmed today, where our population is just over 330 million, and deaths now topping 600,000. We also have data on our vaccination, which is actually one of the good pieces of news in this pandemic, in that we've had a pretty successful rollout and vaccination project, although of course there could be a lot of improvement on this. We see in Taiwan is very, very different situation, and this is very admirable should be for Taiwan, but also for us. It's something we wish we could have. I think we had 33,000 cases last week, which was almost twice as many cases as Taiwan has had completely. So I think what has happened with the pandemic is that it's really pulled the curtain aside on what has been going on in the medical system and the hospital system for decades. What we're seeing in this last year or so are emergency departments doing what we do best, taking care of the sickest of the sick patients, expanding what we do, working long hours, working overtime, working day, night, weekend, holidays, overworking in many cases, and working to the best of our ability in the face of illness and sickness that, especially at the beginning, we did not fully understand. There are some cases where medical personnel, physicians, nurses, first responders did get recognized for the sacrifices, the risks, the overwork, the dedication that they have given. But I think in many places, this is not being recognized, and this is being taken for granted. We're seeing levels of stress, levels of overwork, levels of exhaustion, levels of depression and burnout, and frankly, levels of abuse of our medical professionals that we have never seen before in the last many decades. And what we're seeing, although all of us are, as medical professionals, are dedicated to our profession and to our patients, at some point it becomes dangerous to push people to their limit. And we're seeing, I think, the beginnings of cracks in the system. So now that we're more than 12, 13, 14 months into this pandemic, we're asking the question, where will year 2 of this pandemic take us? Where will year 3 of this pandemic take us? And particularly about public health, I think with this curtain being pulled aside, showing the vulnerable state of the emergency department, the vulnerable state of the hospital and the medical system, particularly in the US, the pandemic shining this big spotlight on the public health system, there is an opportunity here for the public health system to have a new era of leadership. But the question is, will this happen? Will there be the new changes and the maximum better changes that we need? Or will it just be an opportunity that comes and goes and will turn into a lost opportunity. We have seen pandemics happen roughly every 100 or 120 years all throughout modern history. And I think because we only live to be 50, 60, 70 years old, we don't have an institutional psychological memory of this. The last time a pandemic of this magnitude happened, as you know, is 1918. And there are not that many people alive today who were alive back then in a way that they can remember the 1918 pandemic. But what we've this is an open. So I want you to think about this concept of the role of the emergency department. Every patient who presents to the emergency department represents a failure of the public health system. This is Professor Louis Goldfrank, one of the grandfathers of emergency medicine, the head of Bellevue and New York University Department of Emergency Medicine. And he asks his residents when they present the patients to the faculty, not just their past medical history, not just their past surgical history and what their chief complaint, but he also asks them to report what is the lesion in the public health system that caused this patient to have to come to the emergency department today. We have to remember that the emergency department is a safety net for all the holes and cracks in the healthcare system and in the public health system. And we are there to catch the people who fall through the cracks, not just the cracks of the healthcare system, but the cracks in all of our society. Because ultimately all disparity, all inequality shows up as pathology written into the very biochemistry of our bodies. And those inequalities show up as our patients. It leads us to the question, what is public health? Public health is what we do collectively as a society to assure the conditions for people to be healthy. So public health is more than just taking care of this patient, or more than just taking care of these patients. It's taking care of everybody, and everybody helping taking care of everybody, not just to take care of ill people, but to prevent illness. Also to promote health. One of the founders of osteopathic medicine said, it is the job of the physician to find health. Anybody can find disease. So physicians definitely play a role in public health, but public health is more than just medical care and sick patient care. It's prevention, it's health promotion, it's population health, it's environmental health. And it's public health has actually been the main cause of the increase in longevity over the last 100 years. In the year 1900, the average life expectancy in the world was about 45 or 50 years old. And now the average life expectancy has almost doubled since that, only in the last 100 years. And what has been the primary reason why these young people who were born now can now expect to live to be 100 years old? The real reason is public health. Public health has been credited with adding at least 25 years to the life expectancy of the people in the USA, just in 1 century alone. Not medicine, not high-powered MRI or CAT scan or third-generation cephalosporin, but public health. What are the what does the CDC say are the big top 10 causes for the increase in longevity and increase in life expectancy that are due to public health? The 10 great public health achievements that are responsible for extending this life from 35 to 45 years to now, in some places, 80 to 85 years. These are listed here: vaccinations, safer workplaces, safer and healthier foods, motor vehicle safety, infectious disease, decline in deaths from heart disease, family planning, recognition of tobacco as a safety hazard, healthier mothers and babies, and fluoridation. How many of these are things that are only delivered by physicians? Very, very few of them. And so what we see is we owe most of our increased longevity and increased health to public health, not so much to medicine or to physicians as we think. So if we look back at the year 1900, we didn't have a good understanding of disease, of modern medicine. We didn't know that bacteria and viruses and fungus even caused diseases, and we didn't have a good germ theory of disease in 1900. Compare that to now in 2021. What we saw back then was there was very rudimentary public health, not very good sewage, no good germ theory of disease, hardly any real formal and no modern vaccinations. We didn't have antibiotics until the 1930s. We didn't have anesthesia until the 1940s and 50s. And now we have much, much better public health in many parts of the world. Of course, there's a lot of disparities in this area as well, but compared to what we had even a century ago, the public health systems are much, much better now. We had this low life expectancy at age 45 years in the year 1900, now having almost a doubling of that life expectancy just in the last century or so. And we also, in the last 51, 52, 53 years, have had the introduction of emergency medicine as a specialty. Back in 1968, there were only 2 countries that had emergency medicine as a specialty. Now there are over 75 countries with emergency medicine as a specialty, and that number is going up by 2 or 3 countries every year. So I want to ask you the question, if we went from 1900 of having low life expectancy, and we had a nice big steep curve, a steep rise in our life expectancy to the modern times, where is the next big steep curve going to come from? What is going to be the reason for this steep curve here? Is it going to be more public health? Is it going to be something that we discover in modern medicine? I think that what we've seen is that a long time ago we had no emergency medicine. Now we have the beginnings of emergency medicine in almost every country. 30 years ago, the world didn't really know how to build emergency systems country by country by country. And I think 30 years from now, it'll be done in every country. I think the next big steep curve in our life expectancy and in our health will be from modern acute care and emergency systems. What emergency is, among other things, is not just taking care of sick and emergency patients. It's also a form of secondary prevention. It's also a form of taking care of the sickest of the sick who have already been treated with public health. So we need to think globally and act locally in medicine and in public health. And we need to concentrate on the role that emergency medicine plays in public health. I had the pleasure of taking a course at Brown University on pandemic problem solving, looking at surviving and thriving in the age of pandemics. And Dr. Ashish Jha, the dean of the Brown University School of Public Health, and our friend and colleague Megan Ranney, an emergency physician very involved in global emergency medicine development, ran this course that ran over 6 weeks. And you can see many of the topics that were talked about were non-medical topics, things like supply chains and communication and media and inequities and resilience. And I think what we really learned out of this this pandemic was public health is much, much more than medicine. It's much, much more than health. It's also politics and economics and communications and marketing and messaging and supply chains and delivery systems, etc. So we see how all of these systems are intertwined. So what are some of the things that we need to focus on to make our public health systems better that we have learned from this pandemic? Well, one is we need to strengthen our national public health institutions, increasing epidemiologic surveillance and planning national preparedness and response. And what do you know? Emergency medicine does this very well. We are very good at disease surveillance. We're very good at preparedness and response. We need to create more health data managers, creating data collection tools, analyzing the data, using artificial intelligence and machine learning to help look at local patterns or outbreaks. We need to hire more and train more community health workers. Not every intervention or interaction with patients needs to be with a physician. Of course, physicians are very important, but community health workers, locally trained staffs, volunteers, we've seen how important that has been in this pandemic. We also need to convince the private sector to take a bigger stake in public health. Some of the least funded departments in our municipalities, in our cities, in our state governments are the public health offices, and that needs to be changed. There are only 2 universities in the USA where the public health school has a bigger budget than the medical school. And that needs to be at almost every school. And we also need to think about restoring trust in politics, restoring trust in medicine, in messaging, in economics, and we need to address and heal the disparities that are causing this distrust as part of our public health response. So these are just some examples of the many, many billions of dollars that the US has spent on rebuilding public health, and you can see how many of these have direct health applications like testing, contracting, contact tracing, building community health centers, but many of them have very indirect and non-medical applications like supporting the supply chain, data modernization, Defense Production Act for medical supplies and equipment. And so what we've seen is that the public health chain is much, much bigger than just the medical part. So we've seen that although we have some of the best trained, most dedicated personnel and professionals in the House of Medicine who work in the emergency department, and I truly believe that, we can't practice with one hand tied behind our back or 2 hands tied behind our back or 2 hands tied behind our back and 1 foot nailed to the floor. We need equipment, we need expertise, we need places to receive patients, we need places to send patients. So what are some emergency department-based and emergency medicine-based solutions for the pandemic that we're facing now and for the next pandemic that is coming? Well, we heard from our earlier speaker, Dr. Wang, talk about some of these solutions, but I think the concept of triage, and having standing orders put in place, seeing patients in the waiting room, seeing patients in non-traditional areas, having doctors up front, having physicians in triage, bringing orders, bringing the door to doctor time closer and closer together to each other, and then also the use of teletriage and telemedicine. I'll go into each of these in a little more detail. Some other changes: conversion of new patient care areas. We've seen a reduction of non-emergency services like same-day surgeries, outpatient surgeries, scopes of knees and endoscopies, and reduction of the hospital services that are non-emergent and replacing those with inpatient care. And then recruitment and retraining of existing staff. We've seen in the USA not just physicians using telemedicine as a new adjunct, but also having emergency physicians working in critical care. I myself worked 5 or 6 shifts in the ICUs in our various emergency departments. I also worked in our urgent care. I also worked in our field hospitals, and so did many of our other doctors and nurses. And then I also think there's this concept of the procedural list, which I will get to. So some examples of this are standing orders, having patients have orders and medications, laboratory tests being ordered for them by nurses, by non-physicians as part of the triage process. We're seeing in emergency departments across the state, across the country right now, almost all the emergency departments are filled to the rim now. The initial dip last summer that we heard about last lecture, that dip is gone now. Most places are back up to their numbers pre-COVID, and in some places we're above the numbers where we were in pre-COVID. I know here in Maryland, for the last 3 or 4 weeks, every hospital has been on yellow alert, which means the ER is full, or been on red alert, which means the hospital is full. And there were several days per week of this last month where there were 0 beds available in the state of Maryland. This is a big problem, and this is happening state after state. So the way to handle this when you are overwhelmed is to triage. And we in emergency medicine are the triage experts, not just for emergencies, but for all different patients. We heard a lot about telemedicine and teletriage. One concept is having the physicians in the triage using telemedicine technology, if that's possible. So nurses often are 90–95% as effective as physicians in triage, but in a time of crisis, when patients are sick and dying, that extra 5% or 4% of expertise that the physician can deliver by being present, even if by telemedicine in triage, makes a big difference. And so we've seen telemedicine, teletriage, telementoring, and using the expertise of doctors to doctors, not just doctors taking care of patients via telemedicine, but doctors consulting with other doctors via telemedicine. So telementoring, there are a lot of uses for this new technology. And again, I mentioned we need to leverage our data collection. We need to leverage data analysis and use as much machine learning and, where applicable, artificial intelligence for pattern recognition and diagnostic aids. Some other solutions, what we've seen are conversion of new patient care areas. This is a picture of the shock trauma and the University of Maryland Medical Center. But the University of Maryland Medical System is actually 20+ hospitals spread out across the entire state under one umbrella. And what we've seen is at almost every hospital were set up extra patient care areas outside of the emergency department in special areas where we can handle overflow of patients. Sometimes these were COVID designated, sometimes they were completely non-COVID designated, but it was a way to handle the surge, the overflow, the surplus of patients who not only came to the ER and had nowhere to be seen, but people who were also admitted to the hospital already, but had nowhere to go because that hospital was full, and so were almost every other hospital in the area. There was also a lot of creative use of very big spaces like sports stadiums and convention centers. And you can see here in downtown Baltimore, the conversion of, at first, this was a very highly efficient testing area for COVID testing. And now it's testing and patient care and vaccination delivery. And so what some of the last solutions I'll talk about are recruitment and retraining of the existing staff. I think one of the future avenues for emergency physicians is to be the proceduralist. We are experts in a lot of things in emergency medicine, but one thing we are really expert at is procedures. The average emergency physician is trained and credentialed in over 50 different procedures. like intubation and cardioversion and central line placement and intraosseous line placement and critical care resuscitations, et cetera. And what we're seeing in the pandemic is not only are hospitals full, but the staffing is very low, and critical care trained staffing, whether those are nurses, doctors, respiratory techs, those staff are very rare and hard to find. And so what we can do as emergency physicians is something that usually we don't do, is go work in the ICU, go work on the floor, not necessarily taking care of patients the way our critical care colleagues do, but we can come in and do the procedures that other physicians maybe aren't trained in as well as we are. So I have done 4 or 5 shifts like that over the last several months, where I was just wandering the hospital on call, responding to do procedures that my hospitalist or internal medicine colleagues were not trained in. So just to conclude what we've seen with the advent of the pandemic and the advent of the vaccinations, with this one good thing that happened with the pandemic was that we were able to create a vaccine and distribute this vaccine in numbers we've never seen before in such a short period of time. And I think this pandemic itself has shown what's happening behind the curtain, shown what's happening in the ER, something that we've known for a long time, shown what's happening in the hospital, something we've known for a long time. What we've seen is that our hospital, as well as we are trained, as well as we are dedicated, we have vulnerabilities, and the hospital system is like a car engine that's been running at 9,000 RPMs. You can push a very well-built engine to run in overdrive, but not forever. Even the highest, most well-built, well-trained, well-equipped machines will fail when they are overused. What we've seen is this concept of the emergency department as the room with a view. The emergency department sits at this very advantageous point in the healthcare system. When we have our patients being seen in the emergency department, we have the ability to look back in time to look at the lesions in the public health system that allowed our patients or caused our patients to have to come to the ER. We're also seeing from the ER, we can look forward in time and see what are the obstacles and barriers and difficulties for the hospital, that patient will see in the hospital and in the outpatient and in trying to get follow-up. And so we really are kind of like a spider sitting in the middle of a web of the healthcare system, with our 8 legs, feeling all the difficulties and perturbations and disturbances in the rest of the healthcare web. We've seen that the emergency care system is a interconnected web of ER. So when the ER runs well, the hospitals run well. And when all our ERs and all our hospitals are running well, then the healthcare system itself runs well. We're seeing the emergency department is actually like this, this network of mangrove plants. You see this on the coastline of almost every continent. And it's this connection of small, sturdy network of plants, but that together, that network and those roots intertwine and cause a very, very strong network. And so those hurricanes and typhoons that come and strike the coastline, if there is a good coastline of mangrove, this network of resilient interconnectedness, then that typhoon, that hurricane, that disaster, that crisis will exhaust itself and be absorbed by that network. And I think the emergency department and the emergency care system is just like this network. That when we have the pandemic like this, and we have it an everyday emergency system, an everyday emergency care system built over top of our community, then these pandemics will exhaust themselves the way the hurricane will exhaust itself, beating itself and losing its energy on this network. So we've seen when you build emergency departments and when you build emergency medicine, it makes the emergency department run better. But when you have the emergency department run better, that makes the hospitals run better. And when the hospitals run better, that makes your national system run better. And then that makes your whole global economy, your jobs network, your supply chain, your schools, your education system, the other essential workers in non-medical fields, it makes them work better. What we've learned in emergency medicine, but we've particularly learned, and hopefully the rest of the world has learned this, is that the emergency department is the engine to the healthcare system. And that the emergency department is critical to the public health system. We've seen underneath the curtain, we've seen behind into the healthcare system. Hopefully, the rest of the society is learning this the way we have learned this, that this is an opportunity. This is an unfortunate, avoidable tragedy, but it's an opportunity to make the final real and lasting change to the emergency and to the public health system that we've been waiting for decades and decades. COVID has really acted as a giant spotlight, shining a big, bright light on the emergency system, on the healthcare system, on the hospital system. And it's up to us to see, do we act and leverage this goodwill and attention that we have and turn it into the real and lasting change that we need. I think it's clear emergency medicine is public health, and public health is emergency medicine. And this is the role that we play. That's the end of my talk. I'm very proud to be invited and to speak with you, and I'm very happy to answer any questions you might have. Thank you so much.
Thank you, Terry, for your wonderful speech. I enjoy your speech very much. I think I love the words that you quote, that the room with a view. Now we need a more big picture. We need a bigger picture for the development of emergency medicine and for the public health. So I also love the words that you say, emergency medicine is public health. Thank you for your speech. Now we can move on to the last discussion section. Please, Dr. Huang.
I think all of us are all joining the discussion group, so I think we can open some. We can open questions to our audience, or not audience, is our participants. So I think there is. I think there are maybe questions. So I will ask. Now currently on the screen, I have one question. So that is coming from Dr. Lee from Taiwan Society of Emergency Medicine. He say the political disagreement here in Taiwan is awful, as it is in the US. What is the role of emergency medicine in restoring trust in the public health system? So what is the strategy implemented in the US? I think I can ask Sunny to answer first, and then Terry to give another comment, please.
Sure. So I think, there's a lot emergency physician can do here. So I guess clarify for everybody, I happen to take a year of leave between August of last year to July. I just came back to the United States last week, spending a year in Taiwan. So I did get a front row view of how Taiwan handled this pandemic compared to my experiences in the United States last year. And my observation is, I guess, twofold. So first of all, I feel like Taiwan, there is, sure, the political disagreement is awful, but a lot of the disagreement is just more, I feel like just politicians attacking each other, trying to gain votes. But the ultimate goal and the focus is actually very clear in Taiwan. I think it's very clear that everybody want to, basically essentially minimize the absolute number of people infected. And it seems like everybody can be in agreement, even when the outbreak was initially bad in May, lockdown was quick. Versus in the United States, you can't even get people to agree. Do we wear masks? Do we not wear masks? Do we lock down now? Do we not lock down now? And so when you can't even agree on that, it's very hard to move forward and allow the action that then we miss a lot of window of opportunity to really get this pandemic under control. But what I feel like emergency physician really can do here is then patient education. Even as in a small role, even say you're not a very political active person, I do feel like, especially in Taiwan, patient trust doctors, and so this is your chance, right? Your patient is in front of you, is right there in the emergency department. I think this is your chance. Like, you have their ears, they're your captured audience. This is where you can really, as a physician with the authority, tell them, this is the science, this is the fact of this pandemic. Don't worry about all those pundits on television saying this and that, or, they're just trying to sell newspaper, they're trying to sell TV view ratings, right? That's their job. Our job is control this pandemic, take care of patients. So I really feel like when you put it that way, patient is going to listen to you. And then for those who have a more leadership role or have political role or more involved in politics, I do think that this is where we really need to, essentially, like what Dr. Mulligan was saying, this is our chance. This is really, through this pandemic, we already showed the world that, our medical structure, infrastructure cannot survive without emergency medicine anymore. Pretty much everybody is dependent on emergency medicine to be that safety net, or to do that initial evaluation. We are good at what we do. So now is our chance to go back to the leaders of the country and say, look, we really should be given more focus. We need to be given more opportunities in the society. So I really feel like, this is our chance. And I think for those who are in, for the leaders that are here and moderating this, this is where you have we have the attention of the world right now, and to really it's our chance to take advantage of it. I'll let Dr. Mulligan say more, because I'm sure he's passionate about this.
Yes, Terry, please.
Well, I had a change in my travel as well. For the last 20 years, I spend 3 or 4 or 5 months a year overseas, except for 2020. Since February 2020, I haven't been out of the country, which is very odd for me. And I spent that time working double time in the ER. I've always been a full-time person, and now I was working 150% in the ER because of the huge need here. And I think we have multiple different roles to play. I know the question is, what role does what is the role of emergency medicine in restoring trust? Well, I agree. Our patients in general, our patients trust us. Even though we are emergency physicians and we don't have patients who come to us for years and years and years, like a primary care doctor or a cardiologist might, we do have this special role of sometimes seeing our patients in their most vulnerable position. And they trust us in general. They're putting their lives in our hands. And we do have a way to, a role to help them understand the need for masking, the need for social distancing, the need for obeying the lockdowns when those are being recommended, and now in vaccination adoption. I don't know the politics in Taiwan the way I do in the US, but one of the major causes for vaccine hesitancy in the US has been politics. And I think that that's overall a negative result of politics. And patients are at the point now where they don't trust anybody. And when, particularly people who are anti-vax or who are very hesitant about taking the vaccine, I think they won't trust anybody, no matter who says it to them, unless it's somebody they know, somebody they trust, somebody who's in their small circle of friends or family, or maybe key trusted individuals. There was Andy Slavitt, who just ran President Biden's vaccination distribution plan, said all their efforts now are focused on what he's calling the ground game. It's all ground game now. So if we're relying on politicians or the government or our institutions to convince people to get vaccinated, I think those days are past. We actually have to go down to door, knocking, and having our individual contacts do our recommendations for us. In terms of emergency medicine as a specialty, I think we have a huge opportunity to restore trust, because we are there for everybody. We are in the U.S. We're the only specialty that is there, no matter whether people can pay, no matter what time of day it is, no matter whether people are uninsured or have no insurance, or whether they're in the country with immigration status at risk. We see everyone, and we love seeing everybody. And so I think they trust us. In the US for the last 12 months or so, we're seeing emergency physicians, critical care doctors, emergency nurses being interviewed on major news television networks 2 or 3 or 4 times a day. When was the last time you saw that? And so I think we have to use this temporary goodwill that we have in order to make some suggestions, make some changes. If you're involved in the local or national politics of emergency medicine in your country, I think you have a double-sided approach. Number one is to tell your local and national politicians that you are there doing the work that needs to be done right now. So rest assured, if you give us the tools that we need, we will be able to do what we need to do. But more important is, what do we do so this doesn't happen again? And we need to, as we come out of this, knock on wood, if we come out of this in the next 6 or 12 or 18 months, we need to put into place the things that will stop this from happening again. So we have to have stockpiles, we have to have staffing, we have to have training, we have to have increased budgets. Think of how many billions or trillions of dollars have been lost to the world economy for pennies that should have been spent on the public health and the emergency care system. And so we need to make those changes, and we can be advocates to our politicians and to our health ministries and education ministries, finance ministries, to make those changes.
Dr. Chen, we have collected some questions before the meeting. Can you moderate this session, please?
So the question is, when providing care through telemedicine, what are the most common issues that U.S. Emergency doctors face? I think Dr. Wang went over, did a very thorough presentation of, I think, the positives and the negatives. I've been involved a lot in teletriage. In fact, I worked a teletriage shift immediately before joining you on today's seminar, webinar. And I very much like teletriage, and then I also very much have some questions about it, because yes, you can't look in their ears, but nobody really died of an ear infection. What I can't do is I can't push on their abdomen. I can't do a proper neurologic exam. I can't get a sense of how this patient looks and how they're interacting with me the same way through the television as you can when you're in person. And then, of course, if something goes wrong, you're not there physically to do something. So I don't want telemedicine to replace the face-to-face interaction. I think it's a good addition to what we're doing. I am worried, especially in the US, that because telemedicine is so much cheaper to deliver, that the corporate practice of medicine and the corporate interests in insurance and in hospitals will actually over-apply telemedicine and reduce the face-to-face physician time and replace it with more and more telemedicine, maybe too much. And so I think it's up to us as physicians to adopt telemedicine and adopt the things that it's good for, but to limit and to put the brakes on telemedicine if and when it's going to be over-applied.
The Mulligan response. Can there have another question? Next question. Please, Dr. Wang, can you respond to this question?
Yes. Yes. So the question is, I'm going to respond to this one. It says about 70% of adults have been gotten vaccinated in the United States. As emergency physician, do you think it's really feasible that people can get rid of masks once they are vaccinated? And then how about you? Do you still wear masks in public? So I think I'll answer this last part first. And that's because that's easy. Yes, I do. Well, so I should also clarify, I got one shot of AZ in Taiwan, but that is not recognized in the United States. So I do have to start over in the United States. But that, I think regardless, even after I'm considered fully vaccinated, I am still gonna wear a mask. I do have 2 young kids at home though, so I guess that also makes the decision a little easier. But regardless, I guess it gets to the core of the question is, do we really is it really feasible that we take the mask off once vaccinated? I think it just depends on herd immunity. I would say even with 70% adult, but if you look at, I think total population, we're at 40-something%. So really, United States have not reached herd immunity. And also depends on what your goal is. I think if your goal is you don't want anybody to get COVID, well, we know vaccination doesn't stop you from getting COVID. It just decreases severity of the disease. The chances of you being severely ill or even die from it is much lower if you're vaccinated. So if you can accept that, then I think it's perfectly fine to take off the mask. But if your goal is, I don't want to get COVID at all, regardless how mild my specific case is going to be, then I do think then people have to continue to wear a mask. So I think this is going to be sometimes a little bit cultural dependent as well. What is the general sense of the society? Where is everybody at? I do think obviously people would like to take their masks off because, you know, it is a burden. It is an additional thing you have to remember when you leave your house. But at least I would say at least the rest of this year, we're not there. We're not there yet to take off the mask if your goal is to continue to prevent spread and to prevent getting the disease.
Okay, thank you. This panel discussion, we invited our academic director, the Professor Huang Jianhua. Have Huang Jianhua any comment? No? Okay.
Okay, so can you hear me? Yeah.
Yes.
Yes.
Please.
Actually, I have a discussion in response to the telemedicine. We are interested in the emergency department because now actually in many of the hospitals in Taiwan, including our hospital, we use the telemedicine in the emergency department for the pandemic. And actually, I agree with Dr. Mulligan, his point about we cannot do. It's not good. It's not good physical examination. Even we cannot do physical examination to touch the patients for the in the telemedicine use. But the good point for the telemedicine is to explain explain the condition or explain the test result or explain the treatment strategy for the patient and family. So maybe, so I agree that we can add the telemedicine to our clinical practice, but we cannot depend on only on telemedicine. And actually, for this point, I also want to raise another question for when we're using telemedicine, because in the pandemic area, we have our emergency patient maybe at the outside of the hospital. I mean, outside the emergency department to do some triage or waiting for some test result. And in this area, I don't know, it's the same condition in the United States. But as the Dr. Mulligan showed, many like TAM and outside setting, we also see in the United States. So how do you monitor this the patients, or let's say how do you care this patient outside of the emergency department waiting for some test result? Do you still use the same manpower to check the vital sign as usual, or just you know do the less intensive care? Yeah, because some patients in the waiting outside the hospital, they may become deterioration, become conscious change. Then maybe we cannot find their situation in time. So my question is, when you care the patient in the tent or in the camp outside the hospital, do you use the same protocol, or you have another caring protocols? Yeah.
Yeah, please, Dr. Morrigan, have you any response?
Sure. I mentioned in my system in Maryland, we operate 13 different emergency departments, and almost every one of them had an external tent or patient care area like the ones I showed photographs of. And those photographs were actually of ones in my hospitals. In place, it's a little different. Some places were used as the known COVID patients. Some of the tents were used as the non-COVID patients or the non-cardiac patients. We tended to keep the sickest people in the ER, where most of the physicians and the staff and the equipment were, and we would place patients who were emergency patients, but maybe who were more stabilized, who had lower acuity, who we had a chance to see and maybe evaluate, but they were still waiting for test results, still waiting to be admitted. And these were areas where we could move the patients to an outside or adjacent area and then have that critical care room now free again for the next critical patients. The way I used to joke about this is, if you landed in Las Vegas and didn't have a hotel, you could probably find a hotel somewhere in Las Vegas. But what if everybody who was staying at those hotels was staying there for a month? Then you wouldn't be able to find a room. And so one of the things that you need to do with emergency patients is move the patients out of the emergency area unless they absolutely need to be in the emergency area. And so the ones who need to be there, then they stay there. And the ones who can be moved to the adjacent areas, whether that's a tent or a different patient care area down the hall or on a different ward, they can still be taken care of under the emergency department, but they can be physically in a different place. Nowadays, in the US, most of our hospitals have the capability of having mobile computers, mobile vital signs devices that can be moved around to some extent to these tents and to the different areas. But that's not true everywhere. And it's not true everywhere, even in the US. And so each place you kind of have to have, you have to make it up on your own. So I don't think there is a universal protocol that can be used. However, the concept itself can be used, that when we have too many people to fit in the room, then we have to fit them somewhere else. it's up to us to come up with the protocol, the things that are best for us. And what we did is we changed it every 2 or 3 weeks because we learned things. We also had a changing population. As we talked about already, the numbers were changing, going down, going up, going down and up. And then our staffing was going down as well. So be creative, be flexible, tell your staff that the way we're suggesting this week, it's likely to change next week. And then the week after that, it's likely to change again. And also let them know that you're going to listen to what they say and what their suggestions are, because they will often be able to give you suggestions or insights that will help the system run better and be more consistent.
Okay, thanks, Professor Mulligan response. We see another question asked for Dr. Sunny. Is the telemedicine contributed in downtown or other city during COVID pandemic? Please, Sunny.
Yes, I'm
Do
sorry.
you hear?
Can you repeat that? Yeah, can you repeat that question? So it's about telemedicine in downtown. I didn't get all the question.
Yeah. The difference contribution in the downtown space or the city during the pandemic. Yeah.
Sure. So I think, I guess they're probably referring to the slide when I was talking about using it as an interfacility resource management. So I think it doesn't really matter whether it's the downtown hospital versus a rural hospital. It's more about just where are your manpower right now? Where are you underutilizing your manpower? Now, it does point to Dr. Mulligan's point, in the United States, unfortunately, medicine is a very very business oriented. We are constantly looking at cost cutting measure. So that's, is not necessary. I think like I said, teletriage is helpful to help decompress the ED, but I do agree with Dr. Mulligan that as physician, we also need to stand up for ourselves, that we do need to know when to put the brake on and say, wait a minute, when is it getting not safe? Are we using telemedicine just so we can intentionally understaff and you try to use telemedicine as a bridge? So at least early on in the pandemic, that was not the case. We truly had physicians sitting around and doing nothing.
Yeah.
But yeah, so I think, and then within the city itself, if you're just looking at what if I only have hospital in the city and I don't have, partners that are sitting in the rural area, then I think that's where, just like, Dr. Mulligan, you saw his setup, even he is in a very busy, like Baltimore is a big city in the United States. And even within a shop like that, they find ways to, make telemedicine work. So I think just like he said, you just have to be creative. Every hospital has your own unique politics and have your own unique setup. I think you just, and as an emergency physician, we're solution finders, right? We're constantly dealing with the unexpected. So I think, if we all put our minds together, we can come up with some very creative solutions to the problem specific to your hospital.
Okay.
Yeah.
Thank you. Yeah. Okay. We have a question for the Professor Mulligan. Should we modify the original triage to conserve more public health during COVID pandemic? Professor Mulligan, do you have to give some comment?
Well, triage is one of those things that there's very good data now. 20, 30 years ago, there was always a question, should we have fast triage or long triage? Should we have triage being done by nurses or by doctors? Should it be done by techs? Should it be done by computer or color-based or number-based or etc.? And now, after this 25 year experiment, I think we've kind of come back to where we started from. In fact, there was a really good lecture about 10 years ago by the now president of the IFEM, Dr. Sally McCarthy, called "The Death of Triage," which is all the data from all these different systems of triage systems show that they're all pretty much as good as asking 4 questions. Is the patient sick or not sick? Does the patient, are they going to stay in the hospital or not? Can the patient lay down or can they sit down in a chair?
Mhm.
And is the doctor going to need to see them once or more than once? And when you have an experienced person asking those questions, sick or not sick, sit down or lay down, are they going to stay? And does the doctor need to see them once or more than once? That's about as good as most triage systems. Now, it has to be an experienced person doing that. What we've tended to do is throw everything else into triage, like asking the person about their entire past medical history, their entire social history, their entire home abuse and safety history and psychiatric history and everything else. Those are all very important things to know. I don't know whether they need to be done in triage. But should we modify triage to face more public health concerns during the pandemic? Well, I think we have. You know, one of the things that we've really used a lot in triage, and one of the benefits of having tele-triage, of having the physician being in the room with telemedicine in the triage room, not just in the patient care areas, but in the triage room, is that extra little bit of expertise of saying, you know what, this patient needs isolation for their risk factors for COVID. This patient needs to have these 10 or 15 different orders put in right now for their hypoxia and for their respiratory distress, et cetera. And so while our nurses are very well trained and very reliable, they're not trained in the same way as physicians. And having the, that little extra skill set, that little extra training in the triage room, it does a lot when the patients are super sick like they have been during the pandemic. So I think one of with this particular disease, what we did not want to do was bring a sick, infectious, highly likely COVID patient or known COVID patient and bring them into the regular general emergency population. And so by having triage modified to make sure that we identify every either known COVID or possible COVID patient, that worked very well for us. So we did do some modifications.
Yeah. I think the triage have to modify in the pandemic happen. Yeah, I think it's very important. Okay, have the assistant have another. Okay, have another question. Okay, this question is what advice would you give the medical student who are interested in becoming an emergency physician in the pandemic era? Morgan, can you answer the question?
Yeah, well, first of all, I think emergency medicine is the best specialty out of all the medical specialties. And I think if you like emergency medicine and you're interested into it, you should go into it.
Yes.
There's a joke that emergency medicine is the most exciting 15 minutes of every other specialty.
Yes.
So I think if you like emergency medicine and like me, I loved it. I didn't want to do anything else after I did so. And if you're like that, then go into it. Now,
yes,
there's some interesting things happening in the USA, for example. This is the first year in all of emergency medicine history that there have been emergency doctors who have graduated residency that haven't been able to find a job.
Yes.
It's the first year. Just this June, this happened. June and July. And it's because of the pandemic. What we're seeing already in the fall, in September, October, November, is already the hiring is starting to go up. And so we didn't know that until just now, but it looks like the numbers are going back up again. And so I think this is a temporary dip. So don't let a temporary thing like the dip in emergency spots or the dip in maybe a job market. Don't let that influence a 30-year decision for you.
Yes.
I think emergency medicine is spreading all over the world. It's expanding and expanding. We're doing more and more and more. Like every growth, it goes up, and then maybe flattens, goes up and flattens. But it's in general, it's up. And emergency is it's not just specialty number 35 or specialty number 36. It's the specialty that cuts across all of those other specialties. It's the solution for all the cracks in all the other specialties. And I think that's why it has such a promising future. So there are lots of ways for medical students to get involved. There are emergency medicine clubs. There are groups. I would recommend contacting your national society. They almost always have student chapters or resident chapters. And there are also global student chapters if you're interested in doing emergency development in other countries. And I remember in 2018, we had a long discussion with the Taiwan Society that Taiwan has one of the best emergency systems in the world and is in a great position to help other countries in Asia and in all over the world who are maybe 20, 30 years behind Taiwan, to help them build their residencies and their society and their emergency protocols and their emergency curriculum. And so there's a lot of ways to get involved as a student. Number one, you want to graduate medical school, and number two, you want to graduate residency, but you can get involved in your national and global societies early on. Just get your feet wet.
Yeah, I'm 100% agree your concept, because I think we all have the confidence that the emergency medicine in Taiwan will better and better. Yeah. Okay. Have Sunny have any comment that the post-pandemic area? Do you think the emergency physician will practice in the telemedicine will improve our rule or the value? Yeah.
I do believe so, yes. And I think it's just, if nothing else, this pandemic showed how important emergency medicine is to the society, right? Like, I think if anything, it shows how we are just completely irreplaceable. I actually typed the answer to this question on the Q&A as well. So for anybody interested, you can take a look. But I mean, just think about any other specialty like radiology. They're getting replaced by AI. There's AI now that can read chest X-ray faster than any human being, right?
Yes.
So, and then, but just like Professor Mulligan said, we are also proceduralists, and and our skill set really goes beyond the four walls of the emergency department. It's not just telemedicine, but think about, like, you can bring your skill. Like when you're on the airplane, when they ask for a physician on the airplane, they're asking for an emergency physician, right? They're not like, can you imagine a dermatologist trying to respond to a code on the airplane?
Yes.
Doesn't happen. So I think, if nothing, I agree with Dr. Mulligan. But now, granted, we're all emergency physicians, so we're obviously all very biased, probably.
Yeah.
But but I honestly do believe it is the best specialty.
Yes.
That I can bring my skill anywhere to the world, and in any setting. I can be in the wilderness, in the forest, and dislocated my shoulder, and I know how to put it back in myself without anybody else helping me. Like it's definitely the skill set you learn in emergency medicine. It's incredible.
Yeah.
Well,
Okay.
I agree with you. Just to expand on that, I agree with that. We're among the only doctors anymore who see sick patients, who put our hands on undifferentiated, undiagnosed patients, people who we don't know what they're there for. They don't have their diagnosis, written across their forehead. They don't have one day of charting and laboratory and X-ray and stabilization and data. By the time the patient gets to the ICU, even to the operating room, that doctor has 6 or 12 or 20. We have 0 very often. And so it's an amazing skill set. We're taking care of sick people. I think a lot of other parts of the medical system, they have the ability to say, no, I'll see you tomorrow, or why don't you just go to the ER?
Yes.
And we're there, we're proud to do that. But I think we need to be equipped to do that.
Yes.
We can't do it with one hand or two hands tied behind our back.
Okay. Okay, can we show another question? As a superintendent of a university hospital, how do you think about setting up the negative pressure? Oh, what is the question? Yeah.
Well, I mean, we have ER in most of our emergency departments. We have isolation rooms. Some of them we don't, but you can convert a regular room into an isolation room with a mobile air cleaning device. It's basically pulling the air into the room so that patient's virus, if that patient is infectious, that patient doesn't spread that virus all over the ER. In the operating room, it's a little bit of a different situation. Often, by the time patients are in the operating theater, we're having surgery, we often know what their COVID status is. Because nowadays we have, rapid COVID turnaround in 2, 3, 4 hours. But in the emergency department, if it takes 3 hours for us to get the COVID back, by that time, that patient could be infecting the entire emergency department. And so we have to have this negative pressure set up immediately. So I think you have to have the capability for negative pressure for known COVID patients, for very high risk COVID patients, patients who they look like COVID, they smell like COVID, they sound like COVID, but we don't know the COVID test result yet. Well, we have to treat them as if they are COVID. Those people should probably be in negative pressure rooms.
Okay. Have another question. The question is it's a must for future hospital. How U.S. patients will treat by surgeon during pandemic. Maybe this is favored Morgan.
Well, what we've seen is people, I think the public looks at hospital is a place where sick people go when they need to be admitted. And that is one of the things that hospitals do. But hospitals also, especially in the US, they have half of their business is non-inpatient medicine, where they have same-day surgery and procedures and endoscopies and colonoscopies and follow-up for cardiologists and specialty care. And so all of those services in the US got shut down to almost zero. The non-emergent, non-emergency surgeries got shut down because people didn't want to infect the staff or the patients or themselves. That was one of the big reasons why hospitals had such a financial trouble, because for some crazy reason in the US, we run the healthcare system like a business. And when the business income starts going down, we had this weird situation of we had more need and more sick patients than ever before, but we had less and less income to hospitals. And so we had like staff being let go and being laid off. It doesn't make sense. So you can't really run healthcare like 100% like a business. I hope that's one of the lessons that we learned coming out of this. But what we've seen is that one of the things that the emergency department did do was recognize and diagnose patients who did have COVID and find out whether they before they went to the operating room. And if they did have, if this was a COVID patient who needed, let's say, a trauma surgery, then we knew the patient's COVID status because of what the emergency department was doing. And so it was a service that we were offering to the other specialists, you know, in addition to the patients.
Okay. Okay, we have another question. Yeah. The question is the cost of telemedicine and how to arrange the order of the patient visit to the doctor. Can this question answer for Sunny?
Yes. So so cost really depends on where you're starting at. If your hospital system right now has nothing, you know, just the infrastructure. You know, I won't be able to really give you a cost. It can be as simple, at least in the United States, it can be as simple as picking up your iPhone and just use FaceTime and call your patients. And so that is considered a form of telemedicine as well. And that in that case, there's really no cost of setting that up. In terms of how to arrange it in order for the patient to visit the doctor. So at least, so in the United States, so if you're looking at, hey, using teletriage in the emergency department, majority of the time, it is still a nurse that take the patient, at least get the vital sign, whatnot, and then get the patient ready and then get the doctor online. Because ultimately they're trying to still, we know the doctor is the most expensive labor. Their time is the, I guess, the most costly. So in general, most hospitals will operate in such a way that the nurse get as much as possible and minimize the amount of time that the doctor need to do in terms of the data collection. So, you know, vital signs, all that is done. Now, in terms of a teledoc platform, or even say a primary care office that just, you know, doing a routine visit, a lot of times that's only doctor and patient. There's no nurse involved in that. So like when I was a physician on teledoc and seeing patients, is literally the patient requests a visit and I accept the request. I log in, I accept the request, and we just go ahead and start talking. So there's never a nurse involved in that kind of platform.
Yeah, do you think the no triage nurse will be better? Do you think have the
really
triage nurse? Yeah.
So it depends. I think so the way it was set up for our system is the triage nurse is physically located at where the patient is. And that's helpful because the nurse is at least another trained set of eyes for me. So like if the patient is telling me something about their rash and I'm seeing, and she's like showing, but the nurse can sometimes see something on the back and then make the patient turn around and show it to me what looked like on the back. Or the nurse can at least listen to the lung. They can at least push on the belly for me and I can watch the patient's facial reaction to when the nurse pushed down. And if there's like a patient is wincing, I can at least know, okay, when the nurse pushed on the right upper quadrant, that's when it hurt. Because I don't know how your patients, how many times have we had patients tell me, oh, my right upper quadrant hurt, but when you really examine them, it's the right lower quadrant,
Okay.
right?
Yeah.
And so I really do think it's helpful if you do have a triage nurse, it's nice to have that triage nurse that is in the same location as the patient. And then also the, like, for example, like the nurse can hold up a light and at least let me try to look at the throat. I know it's not that great, but at least it's still helpful to have somebody hold up a light or something like that. So that was just my experience as to how that worked.
Okay. Okay. Yeah. Yeah. Thank you. Please show the next question. Yeah, this question is following the question of the triage policy in the pandemic. Do you think rapid antigen test or PCR be necessary in ED triage? Oh, it's a good question. Yeah. Can Professor Mulligan, what's your comment that in the triage station we got the antigen test or PCR immediately? Yeah.
Well, this was a question that came up a lot in the pandemic preparedness course that I mentioned in my talk. And some of the people who designed the early rapid PCR and the early rapid antigen tests were the speakers who talked to us about this. And so I think what the difference between the positivity, the first day or first time of positivity for PCR versus antigen is almost negligible. The PCR becomes positive about 6 or 12 hours earlier than the antigen test. And so there is no real advantage in the PCR versus the antigen test in terms of how fast or how early in the infection that you can get a positive.
Yes.
But they are actually asking different questions. The antigen test is asking the question, does the patient have high enough antibody right now that means that they are infectious? Whereas the PCR test is asking, do they have active infectious disease now, or did they in the past?
Yeah.
So it depends on what question you need to ask. Now, in the emergency setting, in the early days, PCR, the early days meaning what last April 2020. It was like the ancient times of 2020. Sometimes it took 7 or 10 days to get a PCR test. When I first had my COVID test in March 2020, it took 10 days to get the result. Now we get rapid PCR turnaround in 3, 4, 5 hours. Now that's not the same everywhere in the world, but fortunately, that's what we're facing now. And so you run the risk sometimes using the PCR test that you will get a positive result, but the patient does not have infectious COVID. Maybe they had COVID 4 weeks ago, or 10 or 3 months ago.
Yes.
And so that's important information, but that doesn't tell you they shouldn't go to school, or they shouldn't go to work, or they shouldn't be in the emergency department waiting room. And so each test is being used for a different question.
Yeah. Okay. Please show the next question. Yeah, this is for Sunny. The telemedicine is emerging to make it developing appropriate and make it play an important role in the future tele era. When and how should be the key dimension that the EM department and the system need to be redesigned or considered? Please, Sunny, answer response to the question. Yeah.
Sure. Yeah. No, I think I guess in parts, but I hope how this will pan out. So I think if nothing else, because we saw telemedicine is also being utilized across all specialty. And I do hope what telemedicine can do is fix some of the cracks we have in the public health system that Professor Mulligan has been talking about. If you think about it, at least in the United States, it's so easy pre-pandemic without widespread utilization of telemedicine. So many specialty will just go to the emergency department, just go to the emergency department. So what I'm hoping is that now that telemedicine is much more adopted across the system, not just in emergency medicine, but also across all specialty, is that our consultants, the subspecialists, they can at least take a first crack at their patient through telemedicine. And because that's a quicker access, because I think that's the problem in medicine in general, is patients have difficulty accessing physician, especially accessing the subspecialists that may have seen them, but now because it's 3 a.m. or 10 p.m. on a Friday night, then suddenly their only option is emergency medicine. So what I'm hoping for, first off, is as we develop this across all specialty, is that subspecialties see their patient first. Now, if they can't handle it through it's almost like a triage tool, right? Yes, I saw my own patient through telemedicine. This is not something I can handle via a screen, or this is not something, it's just, I just need to reassure my patient. This is something they truly need to be emergency medicine in the emergency department. Then I do feel like hopefully we get, fewer patients that really just come in and get reassured by us and get turned around and go home. But really the ones that then essentially is more of a referral in by the specialist. And then on top of that, what Dr. Mulligan mentioned before, like mentoring, then hopefully then this is at the same time, since the specialist already saw their patient, they can also then quickly get on, some sort of telephone, some sort of platform, and let the emergency physician know, say, hey, I operated on this patient 10 days ago. They said their wounds look red. I just saw them through the video chat. I agree the wound doesn't look right. I would like this patient to be seen in the emergency department, and will you call me back? And I feel like this is much better patient care because there's also physician to physician handoff.
Yeah.
So I think I think this is also a chance as we develop this whole system. This is an emergency medicine. I think we need to advocate for our patient, advocate for our own specialty, and also to show, hey, we want to help. We are here to care for patient, but we need everybody to help pull their weight and make the system more efficient and address a lot of the previous cracks that hasn't been addressed for so long.
Yeah, thank you. Okay, we show the last question, please. Okay, in Taiwan, the ED nurse take the response of triage. If we need to modify the triage during the pandemic, would you think if the ED physician be the best choice of doing triage? Okay, Professor Morgan, please.
Yeah, again, triage, I have a love-hate relationship with triage. Triage is really there to decide who needs to be seen first when we don't have enough beds to see everybody, or when we don't have enough staff to see everybody. If there are open beds, you don't need triage. Just bring the patients back and put them in the beds, and the doctor will see them. But when you have more patients than you have staff, then you need a triage to see who needs to be seen first. And study after study after study shows doctors do not do triage better than nurses. In fact, some cases, doctors do it worse because we want to do the whole doctor bit. We don't want to do, we want to do the whole thing. And so we take too long, and in the meantime, the waiting room starts to fill up. And so study after study shows what you need is an experienced, trained person. Most of the time that's nursing. And what can help is to have the nurse trained and experienced in doing what's called standing orders. And standing orders are doctor's orders that are pre-authorized, that if the nurse finds out that the patient has a respiratory rate of a certain number, or a temperature of a certain number, or they have a certain complaint like chest pain or a chest pain equivalent, that they get an EKG and they get blood tests, and that the nurse can order the X-ray. The nurse is not ordering on their own. They're ordering based on doctor's orders, but they're doctor's orders that are written and studied beforehand. And some of these are on paper, some of them are on computer. They can be protocol. It's not cookbook medicine, but it's doctor's orders called standing orders. And that's kind of a way of bringing the doctor to the triage without having to bring the doctor to triage. You're bringing the doctor's orders to triage. And standing orders in pre-pandemic time were just as good as having a doctor in triage. So when you have a doctor in triage, that's not the same as the doctor doing triage. It's that the doctor's in triage because sometimes, maybe 5%, 7% of the time, some patients, you can see them, look in their throat, write the prescription, and then they go home. They never even have to enter the ER. It's like a fast track for the fast track. It's like a bypass accessory track, like in WPW, right? The patient never comes into the ER. One of my friends, Manny Hernandez, emergency doctor, says, the further you get into the ER, the harder it is to get out. And so some of these patients can just be turned around right at the front door. And so it's like throwing a fishing net over your ER and pulling 5% of the patients out. That's actually a lot. And that makes a difference. And so having a doctor or doctor's orders in triage really helps. Now, during pandemic, we saw that there were so many more patients and there were so many sick patients, and the medicine was changing every week, every second week, that the nurses needed, it actually helped to have a physician in triage there with them. So they were doing the standing orders, but the doctor would say, you know what, I'm also going to order a CAT scan, or I'm also going to order X, Y, or Z. And so that's when it might help. Now that we have teletriage set up for the pandemic, probably it will stay there a little bit after the pandemic.
Yeah, okay. Okay, because the time is limited, the Professor Lin or Professor Huang, do you have another comment for us? Professor Huang Jianhua, or
Yeah. No,
comment?
Yeah, I would like to thanks to Dr. Mulligan and Dr. Wang for the wonderful presentation and response for many actually very interesting and difficult questions, and provide very useful information for our audience. I would like to thanks all again.
Yeah, thank you, Professor Huang.
Thank you so much.
Professor Lin. Yeah, Professor Lin.
Okay, in the discussion, I hardly heard of questions about the public health. I think that Dr. Mulligan is going to give us a big picture about the post-pandemic era. I think that we should think about our role in public health in the post-pandemic area. Somebody said that post-pandemic, we should have resilience and redesign or rethinking. I think that we should rethink and redesign our emergency medicine. Thank you.
Yeah, okay. So we welcome the Chairman Huang to close the conference.
Okay.
And I'm very honored and precious to participate in this section. Okay, please, the Dr. Huang, Chairman Huang.
Thank you for all our moderators, our chair people, and especially to Terry and also Sunny. I think you give us, I think in Taiwan now is a morning, so you give us a very good morning, and I think in US is a very good night. So we hope to see you soon. We hope to see you soon. So we hope to see you in person so that we can change our opinions, we can exchange our practice, and we hope in the future we can always invite you to join for this kind of seminar or conversation. And we hope everyone will stay safe and stay healthy. And thank you. And also thank you to all our audience. For our Taiwan Society of Emergency Medicine, we are going to arrange a serial Saturday morning like this talk. We will try to invite the opinion leaders in emergency medicines. We also thanks for Terry for their advice for the medical students to join our emergency medicine. We can see the enthusiastic and the power of how we love emergency medicine. Yeah, okay. So just for now, we say thank you and we say goodbye to everyone. Thank you. And good night to Sunny and Terry. Good night. Thank you. Thank you.
Thank you. Yeah, thank you.
Thank you.